Hello, everybody. What's up? Welcome back to another episode of A Needle in a Haystack, a behind-the-scenes count of a mucosal melanoma survivor by killing cancer with TILs. I'm Chris White, mucosal melanoma survivor, thriver, advocate, inspirational speaker, and self-published author of Killing Cancer with TILs. Real quick before we get going, just a little disclaimer. I am not a medical expert. I am only an expert on my story and my experience. If you need any medical attention or advice, please seek out your care team. Okay, here we are at episode 8. Picking up from episode 7. Up to this point, I had a handful of surgeries, tests, procedures, and it is now November 27th and 28th. Since the last episode, just to kind of catch you up and everything, I've been diagnosed. I was told to seek a second opinion for a specialist. What I had was extremely rare. It's anorectal mucosal melanoma, which is not caused by the sun. It makes up 1% of all melanoma. It forms in mucous membranes, and it's very aggressive, extremely rare type of cancer. Okay. Was really glad I sought a second opinion, see some specialists. And up to this point, I had, in the beginning of August, done a MRI and a CT of the abdomen and pelvis, along with some ultrasounds, followed up by a sigmoidoscopy, which did have some pigment on it that they were not able to biopsy, which is why I did a colonoscopy. And those samples did come back positive for melanoma. Okay. All of those tests and everything from that visit in the beginning of August was to determine my path of treatment, which was going to be a lymph node dissection surgery, which would also include a wide excision, along with 5 doses of targeted radiation to follow at my primary tumor site, which was my rectum. After I had healed from that, I was to return back down to Houston to do a PET scan for restaging, and then to determine the treatment from there. In addition to I had also scheduled a ultrasound biopsy because I had a lump that grew back in the exact same spot where my original lump in my groin grew, that was a lymph node, along with some other tiny spots. And so they were able to get me in on the day of my follow-up appointment, right before it, on November 28th. A side little episode after this to kind of follow up on some things that I think are pretty important to remember, and a few takeaways. But stay tuned, and here we go. Let's rock. The morning of November 28th, 2018, I was able to do a ultrasound biopsy for the suspicious lumps in my groin. These are the results. U.S. lower extremity limited right, collected on November 18, 2018. Ultrasound evaluation of the right groin demonstrates a heterogeneous subcutaneous mass measuring 4.5 by 1.5 by 2.4 centimeters, which is predominantly solid with a few cystic foci. There is internal color flow. This is compatible with metastasis and was targeted for biopsy. There are suspicious hypoechoic right groin lymph nodes, a irregular lobulated right groin lymph node measuring 1.7 by 0.8 by 0.9 centimeters. Another suspicious right groin lymph node measures 1.6 by 0.8 by 1.4 centimeters. Ultrasound evaluation of the left groin demonstrates a symmetric lymph node with focal cortical thickening measuring 1.5 by 0.6 centimeters, suspicious for a metastatic node. Suspicious for a metastatic node. Additional sub-centimeter avoid lymph nodes and left greater with fatty hillock in the left groin are benign appearing. Results. Impression states, number 1, suspicious right groin mass and right groin lymphadenopathy in keeping up with metastatic disease. A suspicious left groin node is also noted. Number 2, percutaneous ultrasound guided fine needle aspiration of the right groin mass was performed. Preliminary cytology results were positive for malignancy and final results are pending. Pre-procedural diagnosis, right groin mass. Post-procedural diagnosis, right groin mass. Preliminary cytology results were positive for malignancy and final results are pending. Estimated blood loss, negligible. Immediate complications, there was no immediate complications and the patient was discharged in good condition. So, up on the pathology results, the specimen source was a lymph node right inguinal. The initial assessment at the time of aspiration was adequate, cellularity, favor malignant. Gross description was a 4.5 centimeter mass. Immediate assessment for specimen adequacy was made by one time. The diagnosis, metastatic melanoma. These are the following results of my brain MRI with and without contrast done on November 27th, 2018. Impression, negative for intracranial metastasis. Indication, restaging scans for patient with metastatic melanoma. Comparison, outside MRI brain on 7/12/2018. Findings, ventricles are normal in size and configuration without hydrocephalus. There is no acute infarction, mass effect, or midline shift. There is no abnormal parenchymal or leptomeningeal enhancement. Major intracranial vascular flow voids are maintained.
Immunotherapy, right?
Yeah.
And you just had a PET CT?
I had a PET CT yesterday. I had a brain MRI yesterday. Yeah. I had blood labs drawn yesterday, and then this morning I had that biopsy. And then I see y'all, and then I see Dr. You. And then Friday I'm supposed to get my port put in, and then Monday I'm supposed to start my chemo.
All right. So brain MRI is clear, which is good.
Yeah.
But as you feel, it looks like the cancer is growing. And the PET CT shows that the disease has spread, unfortunately. So there are some lesions in your lungs, there are some lesions in the liver, there are some additional soft tissue lesions, which means that we'll have to be a bit more aggressive with the therapy, and the plan will probably change. So instead of getting what's called adjuvant therapy, you'll be getting systemic therapy for metastatic cancer.
Cool.
Explain that in layman's terms.
It's a similar therapy, and that previous chemoimmunotherapy is still a possibility later down the line, but going to give you aggressive immunotherapy, and he's going to talk to you about this. I'm just telling you that now that we know that the cancer is in your liver, it's also in your lungs, we need to be as aggressive as possible.
Yeah.
So previously we were dealing with more of a local problem, but now it looks like we have to attack every cell in your body, and the best way to do it is doing immunotherapy combination.
Well, that's what he wanted to do to begin with, but my insurance supposedly denied it. Do you got to resubmit that?
No, I think again now the situation is different. Now we know that the cancer is more advanced, and it was more advanced. We just didn't know about it, and now unfortunately the scans revealed it. It takes some time for it to grow and get detectable. I'm sorry about the news, but I guess you were expecting something along these lines, given the fact that you.
I just thought that maybe like this, we just might have to do another surgery on this. Wasn't expecting all that other shit you just said, so.
Right. technically speaking, the situation would be the same, because if you have disease here, there, it's already metastatic. We just have a couple of additional lesions in other organs, so we would still be treating them in the same way with
cool. So let's do this. Let's get examined. Let's get in here and then.
Makes sense.
Yeah, let's go, dude.
Do you wanna look at the scan?
Yeah, pull it up.
I guess this one is probably the easiest one to look at.
Yeah.
This is your bladder, these are your kidneys, and these normally light up. But we also see these lesions.
Oh fuck, dude, that's a lot.
Yeah, the black lesions are unfortunately new. There's this lesion in the liver.
That's fucking huge.
Which is pretty big. And there's this area that you can feel, right?
That was all clear just how long ago?
The previous scan.
My first PET scan was in July.
Yeah, so that was the previous scan. So at that point you just had the lesion here, but there was nothing here, nothing in the lungs. You see that it's pretty aggressive, but we have good therapy, so we'll start and we'll see how it goes.
Yeah. Okay.
We'll talk to you in detail about the expected responses and things like that.
Yeah.
But we definitely have patients who have complete responses, and
Good.
yeah.
Could you pull up that first image? Can you take a picture of that so that he has a copy, or
Oh, sure. That's
not that one?
No, I want to take a picture
the
of both.
new one.
No, leave it.
Okay.
That one too.
I pulled the other one.
right. Do you guys want to?
Yeah.
Yeah. I didn't pick up on that.
These are the results from the PET CT done on November 27, 2018, and going over the results on November 28, 2018. Impression: metabolically active metastasis involving right groin with suspected spread through inguinal canal into peritoneal cavity, the liver, lungs, and possible node at the thoracic inlet. These are new compared to July 2018 PET CT. Narrative result: clinical history. 36-year-old male with metastatic melanoma of the anus. He had surgical resection in August 2018. 5 by radiation therapy completed in October 2018. He is being considered for additional systemic therapy. Indication, restaging subsequent treatment strategy. Comparison. Comparison is made with limited images from outside PET CT scan dated July 11th, 2018. Findings, head and neck. No hypermetabolic or suspicious progressive cervical lymphadenopathy, no focal abnormal activity within the brain, which is unremarkable on contrast CT images. Paranasal sinuses and thyroid are unremarkable. Chest. There are new metabolically active, rounded, bilateral pulmonary nodules. For example, a 1.6 centimeter nodule in the right upper lobe on image 156 with SUV 6.38, a 1.1 centimeter nodule in the left lower lobe on image 167 with SUV 3.54. There is metabolically active soft tissue fullness in high left paravertebral region at the thoracic inlet, about 1.5 centimeters on image 132 and SUV 4.92. New compared to July 2018 PET CT. Abdomen and pelvis. There is a metabolically active, partially necrotic 5 centimeter mass in posterior right upper liver, for example, on image 214 with SUV 8.20. There is a new 4 centimeter mass in the right perinephric region, colic gutter on image 270 with SUV 12.57. A subtle 0.8 centimeter nodule in lateral left abdomen just below the splenic tip and anterior lateral to the colon is seen on image 240, although without focal activity above regional background. There are compatible with peritoneal spread of tumor. There is new metabolically active mass in medial right inguinal region about 4 centimeters on image 350 with SUV 12.80. A metabolically active small nodule appears to be in the region of the right inguinal canal on image 340 about 1 centimeter and SUV 10.96. Metabolically active nodules are also seen in region of base of right scrotum abutting cutaneous surface, for example, on image 350 with SUV 15.86. Occasional diverticula are noted incidentally without acute compilation. Musculoskeletal, no focal, hypermetabolic osseous lesions.
How you doing?
Yeah.
It's a horrible look, isn't it? Have you seen the scans?
Yeah, that's
Okay, good. Well, you know, there is evidence of disease that's recurring at other areas.
And like the very first surgery I had, there was that lymph node that was up here, and then the second surgery I had up there also, and then you did my third surgery, which was like that big surgery, or whatnot. Well, that other lump that's grown looks like my original one.
Is that right?
And then there's all these little ones that are growing along the side of my scrotum, or whatnot. And then when I was coming up to get my mold made, I was trying to get in to see you and Tara, but it was last minute and busy, couldn't do it. But the day that I started my first radiation treatment, I saw Tara and she looked at it, but thought that maybe this was like scar tissue along the scrotum.
Yeah.
Or, still swelling or fluid buildup from, because I didn't notice anything until after the surgery and the swelling started going down.
Mm-hmm.
Or whatnot, and I thought maybe this part was still kind of fluid, and then the stuff along the scrotum, they just felt like little bitty BBs or like fruit seeds, like a sunflower seed after when you take it out of the shell, real kind of small. And then wasn't sure if it was something related to post-surgery or post-radiation or whatever. And then last week I was kind of like freaking out. I'm like, well, dude, I'm supposed to fucking start chemo and shit, and I'm like, what the fuck is this? Am I supposed to have a surgery? And I don't have a clear answer, and then right, I had that biopsy literally right before I came in here this morning. They were wanting to do it yesterday, but I want to make sure my PET scan showed up clear. So I was kind of like, thinking, yeah, this might be this, and we might have to do this, but my biggest question was, well, do I do chemo first, or how? Over here is like, yeah, no, now it's in your lungs, it's in your liver, yeah, this is that, and we're going to start some therapy that's not chemo or whatever, but...
Yeah.
So yeah, dude.
I think that, it looks like it's...
I mean, I was just kind of shocked. I was like, we did all those surgeries and all those tests, and then we did this surgery, and then it literally, like, it's like the chemo was laughing at us. It was, or not the chemo, the cancer. It was like, oh, you're going to get us from over here, but we're just going to sneak around this fucking sideline, pop up over here, like,
Yeah. I tell you, I'm surprised too. It's very unusual for it to come back this aggressively.
And that quick?
Yeah, this quick, yeah. This is, in folks who have the disease coming back, we're usually looking at that like 2 years from now when it's coming back. Not like this kind of a short time course. So I think it's catching everybody by surprise that it's being this aggressive. The thing is, we do know from some recent studies that the immunotherapy can be real effective with mucosal.
Hyping it all up or whatever.
And when it goes away completely, it can be curative too. And so I think that immunotherapy is like a good option. Honestly, the chemotherapy can be good at making these tumors shrink also. And for a long time before the immunotherapy, we could see mucosal melanomas like anorectal melanoma, that spread around at other places, shrink away with the chemotherapy. But the problem is kind of like what sequence would make the most sense. The chemotherapy can be hard on the immune system, and so if the immune system is going to work, then it probably makes sense to use that immune system treatment first, and then if it's not working, there's another good option, which would be the CBD treatment. So there's a couple options. I think it's just a matter of what sequence makes the most sense, and it probably makes sense to do the immune therapy first.
This thing he's got me doing, it's whatever it is. It's like I gotta go on Monday. It's for like an hour. 3 weeks later, I go back in and do it again, and in 3 weeks after that, he wants me back here for another scan. But he wants 4 cycles of that or something. But I don't know. At some point, I would imagine you'd have to remove this shit. I'll let you look at it in a second.
It depends,
unless it just disappears on its own.
Yeah,
But
the one thing with there being tumors at other places, removing it now wouldn't make much of a difference, right? Because there's still other disease that's growing. But sometimes we see that all the disease goes away and one spot is left. And if that's the case, then it usually makes sense to remove that one spot or 2 spots because there's something that's avoiding the immune system.
You can't do that. Like down here, you don't do that to people's lungs and liver, like going in surgically remove that shit, do you?
Sometimes.
That does get...
If it's necessary, But honestly, what we're wanting to see happen is your immune system wipes it all out, and we don't have any disease to deal with again.
Well, yeah.
And it can happen. We've seen that with this kind of treatment before. So I think the good
when
news,
it's been this aggressive and with that treatment?
Well, the good news is the more aggressive the tumor is, usually the more likely it is to respond. So that's the good thing. If there's anything good about having this be this aggressive. So I think starting the treatment makes real good sense. It removes the immune suppression cells out of the melanoma. There are some cells that can suppress the immune system, and the melanoma has a way of attracting those cells into the melanoma, and that's probably how the melanoma avoids getting destroyed by the immune system in the first place, because it has all these cells there that when your immune system comes in to attack it, they get turned off by these suppressive cells. And so the treatments that you're going to get removes all those suppressive cells. So if you have cells in your body that can attack that melanoma, and you should, then they can attack and destroy that melanoma, because it's something that shouldn't be there. Your immune system should be clearing that up. And it's a therapy that, like I say, has cured people in the past, has cured people with anorectal melanoma, and so we're going to be looking for that to happen.
Yeah, cool.
Yeah.
All right, man.
And if it gets rid of all of it, then there's not going to be a need for surgery. If it gets rid of all of it, but just a couple spots that are avoiding the immune system somehow, we would want to remove those and get rid of the rest of the disease. But let's see how it goes.
You got Tara running around like a
I know.
all over the
she's
place or
like,
some shit.
We've got to do all kinds of crazy stuff today.
I got you.
But it's just bizarre. Well, I'm so sorry this is going on, but it's the right kind of step for the next
Yeah.
thing, and it's kind of shocking that it's this aggressive, but we got plenty of aggressive treatments.
That's good.
Yeah.
Okay.
Good to see you again.
Alrighty, man.
Let me see. I'm not sure. Team's all squared away with you, but we'll get you free here soon.
All right.
Okay, real good.
Thank you.
You bet.
The following are the notes that my mother had took from our appointment with the medical oncology on November 28th, 2018, after we had done my PET scan, my brain MRI, and my ultrasound, done labs, and then met with him to go over the results. These are the following. Brain MRI, clear. Cancer has metastasized to liver and the lungs. Changing treatment plan and starting immunotherapy immediately. First line of defense. Chemo as a second line of defense. Opdivo plus Yervoy. 35 to 37% response rate in mucosal melanoma patients. 50% shrink or remain stable, and results can be very long-lasting response. Potential for a cure. Chemo has a higher response rate, but the type of response is tricky, and even though tumors may shrink initially, they grow back. No port needed for treatment. We will have 2 cycles, once every 3 weeks, and then scan again. After surgery, tumors in groin begin to come back. He had a biopsy earlier today on the node in the right groin, and it is also melanoma. Surgery is no longer an option. Systemic therapy is needed. Sometimes you won't see immediate results with immunotherapy, and it can get worse before it gets better. 5 to 10% have a delayed response. 2 cycles, once every 3 weeks, then scan, then continue for 2 more. Total of 4 cycles. And if Chris is responding, then Opdivo alone once a month. Side effects, see handouts, are not like chemo. Let local oncologists know first, then specialist in Houston after. Don't wait. Let both doctors know. Communication is key. Thyroid, pituitary, adrenals, diarrhea, liver inflammation, heart, shortness of breath, fatigue, confusion. Immune system can attack other organs in the body. Extreme fatigue, call the mucosal melanoma specialist. We'll add chemo to routine if needed. I had done some testing in regards to my gene mutation. These are the results. Mutation, I have a gene called CDK4. May be able to get a drug in a clinical trial or insurance to pay for drugs to inhibit the mutation. Even if disease is stable, mucosal melanoma specialist doctor wants to pursue. We'll see how Chris responds. May need to do chemo short-term combined with immunotherapy. Xanax prescribed for anxiety. Wants Chris to exercise. Aerobic exercise. 30 minutes a day. Some strength training. Do not take any herbal supplements without talking to the specialist. Cannot say yay or nay on cannabis. No smoking. Shortness of breath, persistent dry cough, call immediately. There is hope. The more aggressive the tumor is, the more it responds to immunotherapy. This treatment has cured people.